Good afternoon, everyone. Our webinar is beginning, and my name is Steve Love, President, CEO of the Dallas-Fort Worth Hospital Council. We want to welcome everyone for being here today, and this educational webinar is hosted in coordination with hospital pricing specialists, and they're a very active associate member of the Dallas-Fort Worth Hospital Council. Today's topic is a very important one, unveiling clarity, a strategic blueprint for hospital pricing optimization. We hear a lot about hospital pricing. You hear a lot on the federal level and the state level. So we're going to really get some good information today. This should be a great topic. When you look at your revenue stream pricing categories, you need to identify different effective pricing tactics, develop a logical pricing methodology based on cost analysis, reimbursement rates, and your peer pricing data. We're absolutely delighted. We're absolutely delighted to have with us today Randi Brantner, Vice President and Chief Operating Officer at Hospital Pricing Specialists. We have a terrific turnout. We're looking forward to the presentation. Before we begin, though, if you have questions, please type them in the question box, and we'll strive to answer those towards the end of the webinar. And so with that, it's my pleasure to introduce Randi Brantner. Thank you for being here, Randi.
Thanks, Steve. Thanks for letting us stop by and meet with you guys to talk a little bit about pricing strategies. So good afternoon and welcome, everyone. My name is Randi Brantner, and I am the VP of Operations for HPS, which stands for Hospital Pricing Specialists. So as Steve said, clear and accessible pricing is crucial for all hospital providers, whether we're navigating our high deductible plans or just trying to save a few dollars, right? So this presentation focuses on developing effective pricing strategies, which includes insights on enhancing price transparency, fostering competitiveness, and ensuring appropriate reimbursement. So our objectives today include outlining the revenue stream pricing categories and associated considerations for each of those. We're going to identify effective pricing tactics for each of those revenue streams, and then develop a logical pricing methodology based on either cost, reimbursement, or peer market data. Now, ultimately, this presentation should arm you with the knowledge necessary to improve financial sustainability through strategic pricing. It will also enhance patient satisfaction with transparent pricing, boost competitiveness, and ensure appropriate reimbursement. Now, hospital pricing can be an overwhelming subject, so I hope that I can bring some clarity by breaking it down into more manageable sections and introducing pricing approaches for each of these areas. First, a little bit about HPS. So at Hospital Pricing Specialists, we bring over a century of collective experience in charge master management, healthcare pricing, reimbursement, and payer analytics. Our leadership team, shown here, has successfully completed several pricing projects for hundreds of clients, from critical access size hospitals to large healthcare systems with several thousand beds. We excel in enhancing hospital revenue cycles through effective charge master management, charge capture, coding accuracy, and streamlined billing processes. Our deep knowledge and extensive experience make us a reliable partner in navigating the complexities of healthcare pricing and charge master management. So without further ado, let's jump into the topic at hand here. So first, we're going to talk a little bit about pricing and hospital revenue streams. So hospital charges are intended to represent the statistical basis of cost for hospitals. So although hospitals are reimbursed differently, whether they're OPPS or critical access hospitals, or obviously your other managed care payer contracts, we still see charges divided into these basic revenue streams. These revenue streams include observation and room rate charges, emergency room and clinical services, so chemotherapy, wound care, hospital-based clinic services, our CPT and HCPCS coded procedures, so those are our diagnostic and therapeutic services that are common in radiology, lab, and rehab. Operating room services, that covers the technical anesthesia, so the hospital component of anesthesia services, operating room charges, and recovery or PACU services. Pharmacy products and medical supplies are the other revenue streams that we're going to discuss today. Now, the thing missing from my chart here is professional fees. We do consider that its own revenue stream, but the variability in how facilities handle professional fee billing really does merit a separate discussion. So we're going to focus just on the hospital side of the charge master today, but if you do have questions regarding professional fee pricing, feel free to contact me directly. So when new charges are created, many revenue cycle professionals will look to the Medicare OPPS fee schedule to develop the initial price. This is a preferred method because Medicare payment rates are intended to represent the cost of providing the service. So even if you're a critical access hospital, using the OPPS fee schedule is an appropriate strategy. So as I mentioned before, hospital charges are intended to represent that statistical base of the cost for hospitals. So some facilities will perform studies of capital, supplies, staffing, or other resources to develop pricing in some areas. Although this does require significant work, performing a capital study such as this does help to ensure pricing is appropriate according to resource utilization. But in the long term, this strategy can be cumbersome and hard to manage. Now, most pricing vendors like ours compare a facility's charges to peer charges reported in the Medicare claims file. And this is according to the most recent data released by CMS in the inpatient and outpatient standard analytic files. This gives our clients access to hospital charge data for every reportable charge for every hospital in the Medicare claim file. That includes inpatient, outpatient, ASC, physician, and independent testing facilities. Medicare data is the most accurate and comprehensive source for comparing charges between hospitals due to the fact that almost all U.S. hospitals do participate in Medicare, and hospitals are required to charge the same price for the same service, regardless of the patient's insurance payer. Now, since Medicare publishes this data, it's readily available and an accurate source of hospital peer group charge data. So all those three bullets are the primary pricing strategies: reimbursement-based, cost-based, and market-based. Many facilities will use a combination of all of these strategies. So I'll walk through those various combinations soon, but I wanted to take a moment to talk about the ongoing maintenance of pricing. Hospitals have traditionally implemented uniform annual price increases. This method was deemed sufficient prior to the era of price transparency. This practice involves raising all services by setting a set percentage each year without consideration of market conditions or competitor pricing. With the advent of price transparency, various stakeholders like our consumers, our patients, right, the press, researchers, they all have access to this detailed pricing information through our price transparency machine readable files. So this shift has significant implications for hospitals that have relied on that uniform price increase year over year. So specifically, if a service was priced high maybe a decade ago, has now become even more excessively expensive due to that compounded annual increase. This obviously can result in public scrutiny and a risk to the hospital's reputation. So our new environment really necessitates a strategic approach to pricing. So hospitals should really take into consideration market data to make those informed decisions about which prices to adjust. Now, some prices may need to be increased, while others should be lowered to remain competitive to avoid the pitfalls of that price transparency. Adapting this approach will help hospitals align their pricing strategies with market expectations and mitigate the risk of negative perceptions. So let's talk a little bit about we're going to apply the various pricing strategies across our revenue streams. So we'll start with observation and room rates. So daily hospital services like observation and room rates are used to represent all routine nursing and facility resources. So because of this, reimbursement for room rates is generally incorporated into DRG reimbursement for the patient's inpatient stay and should be priced according to a geographical peer group, which that data is available in the Medicare claims file. Otherwise, that study of capital, supplies, staffing, other resources that could be performed to determine a patient price. Again, that requires significant work, but it does help to ensure the pricing is appropriate according to actual resource utilization. Now, I will say many hospitals don't see inpatient room rate charges as much of an issue as compared to other areas when it comes to patient satisfaction. And this is because insurance payers will generally collect the same deductible or coinsurance, regardless of how much the hospital room rates are. Now, hourly observation reimbursement, that's going to be a little different by payer. We're going to see things like case rates, percent of charges, fee schedules. So we like to make sure that the observation hourly charges represent 1/24 of the daily room rate charge. Now, we do see some facilities that have a front-loaded first hour and lower 2 to 24-hour charges, and that's acceptable as well. But again, 24 hours of observation should be equal to the daily room rate. So as I said earlier, the Medicare claims data is what we rely on for our pricing data. So this is a sample of what that data looks like for an observation hourly charge in that data. So we're looking at G0378 and revenue code 762. This data allows the user to determine the reasonableness of their charges compared to its peers using HCPCS and revenue code combinations. In our example here, primary medical center is at the top of the market at about $113 an hour. And our demo hospital is down at the bottom at around $21 per hour. The average falls in around $65 or so here. But from a market perspective, when we compare demo to our average, the demo hospital has room to increase this charge. But again, we need to ensure that this increase in observation charge is also representative in the daily room rate. So now we'll move on to emergency room and clinic visits. So emergency room visits are reported under the 9928 and 9929 series. So pricing these charges at a multiple of Medicare reimbursement or the average of the peer group data is the recommended practice. Meanwhile, G0463 is a little different. And so for those of you who have been around for a while, this code series was previously broken into acuity-based new patient and established patient codes. So that 992 and 9920 and 9921 series of codes. Medicare decided they were going to bring that all under one code. And although it's really simplified our billing process, it does present challenges when we're looking at pricing data in the market or setting prices based on visit acuity. So generally in this area, we recommend pricing the clinic levels at a multiple of reimbursement or peer group average. But this new code being all under one acuity, one code, we have to get a little creative. Because some managed care payers will still accept the detailed levels, the 99201 through 205, etc. So to kind of get around this, we recommend pricing at either a multiple of Medicare reimbursement or the average of the peer group for that mid-level visit. So for example, we set the price for the mid-level visit at a multiple of reimbursement or the peer average, and then price the other levels higher and lower based on their acuity at a percent above or below that mid-level rate. Meanwhile, ensuring all of it is above your other published reimbursement amounts. So this is sample data for a mid-level ED visit. Same kind of view here, where we have 99283 reported with revenue code 450. Demo hospital is faring a little better at $573 with the market at this level visit, but still has some opportunity to increase. Now, this slide also shows us that local clinic is very high compared to the others in its group, which could mean that this hospital is maybe a higher level trauma center or something along those lines. It may not be a relevant competitor for demo hospital. So that's something we have to take into consideration when we're looking at pricing. CPT HCPCS coded procedures. So these are our diagnostic and therapeutic procedures that are assigned a specific CPT or HCPCS code. Now, reimbursement will vary by payer. We may see case rates, fee schedules, percent of charge, but as a rule, we like to stay within that multiple of Medicare reimbursement or the average of the peer group data. keeping in mind any other posted fee schedules you may have from other payers. Now, the exception to this rule includes items that commonly have patient satisfaction issues. So common areas for this type of price pressure include lab, outpatient lab, CT and MRI, mammography, and rehab. So these items should be identified and priced competitively against other data sources if we can find them, such as freestanding laboratory data or radiology center averages. So as an example, some of our clients will select the top 20 laboratory tests and create an outpatient pricing tier that targets those prices that are commonly seen in laboratories like Quest or LabCorp, which allows those charges to be more comfortable to communicate to patients that are shopping for those tests. And that really allows us to be more retail oriented in this revenue stream. So again, another sample data slide. This is 85025, which is a CBC. Reimbursement is packaged into most APCs. On lab-only claims, this particular HCPCS code comes in around $10, I think, in reimbursement from Medicare. But as you can see, the peer prices for this HCPCS code range from $46 to $357. There's local clinic again, right? With the average falls around $130 here. Now, local clinic is still looking to be high with the other peers in this group, so we would probably look to see what we need to do to adjust that peer group. Now, we could charge this at a multiple of reimbursement or the peer group average. In this example, though, if we were to price this charge at 3 times reimbursement, we would still have this charge below market average, right? $30 versus $130. So targeting the peer average may really help to improve commercial payer reimbursement without causing it to be out of line with the market, because your commercial payers are going to pay a percent of charge or maybe even a higher fee schedule rate for that charge. So using that OPPS fee schedule rate maybe isn't always the best method for pricing CPT HCPCS code items, because we do really have to keep an eye on that market. So again, making sure those are above fee schedules, but in line with the market at the same time. Now we'll talk about the components of surgery. So as I mentioned earlier, we've got operating room, anesthesia, and recovery. So operating room charges represent the hospital component of OR services. So this includes the setup, staffing, and any sort of special equipment, whether it's rental equipment or special equipment you have to bring in for the procedure. Hospitals will either set up charges based on individual procedures, so procedure-based charging, or create acuity and time-based charges according to the staffing cost and additional equipment charges. Now, if they do use time charges, those are determined according to the start and stop time in the surgical record. And then the use of special or rental equipment should be captured by bumping the procedure to a higher level. And I'll show you that in just a second, I think, yeah. So this is a sample of a leveling tool that illustrates how an acuity level could be determined and therefore priced. For example, if a procedure has less than 30 minutes of setup time, we would follow the left branch of our decision tree. As we continue on, if the procedure has no additional staff or no rental or special equipment, it would result in a level 1 or a lower acuity surgical level. This charge would be set up with a front-loaded initial time frame, such as 30 minutes or and then additional 15-minute increments. Now, on the other hand, if a procedure has more than 30 minutes of setup, it has additional staff and rental equipment, we would bump it up to a level 3 procedure. So the acuity leveling methodology allows the facility to account for the use of resources for a normal procedure. Meanwhile, using those additional time increments really allows the facility to capture more complex cases and resource utilization. Now, again, because reimbursement for operating room levels is included in the overall surgical package for the most part, we don't really have the capability to price these specific charges at a multiple of reimbursement or peer average. So we recommend pricing reflect resource utilization in time-based increments. Now, as mentioned previously, some facilities prefer to use procedure-based surgical charges, which in this case, this leveling methodology would not apply. But these procedure-based charges would be priced according to the peer pricing data or a percentage of reimbursement if applicable, similar to how we handle CPT or HCPCS procedure methodology. Now, if a facility is using time-based and or acuity-based operating charging methodology, we recommend reviewing the opportunity at the revenue code level. So this slide shows us how the 360 revenue code looks in our demo environment. We're able to evaluate the revenue stream at the 30,000 foot level, basically, which gives us insight on the severity of cases performed. Now, when you dig into this data below, local clinic performs more acute procedures like prostate removal, kidney removal, hernia repairs, and hysterectomies that the other facilities are not performing. Now, as you can see in the sample data, Demo Hospital likely has smaller OR service line, less acute procedures. So when we're reviewing the other revenue streams, we already know that prices are low in these revenue streams, which is likely true for this area as well. Now, if a facility is using procedure-based or CPT HCPCS-based OR billing, the market data is available at the CPT HCPCS code level, like what we see here. As you can see in the sample data for this cataract removal, Demo Hospital is extremely low compared to its peers. Again, just focusing on the HCPCS code revenue combination. Main Street Hospital is charging almost $13,000 for this procedure, with the Demo Hospital charging a little more than $2,000 for the OR charge of this procedure. Now let's talk a little bit about technical anesthesia. So this is the hospital side of anesthesia administration. Now, managed care contracts generally do not allow reporting both itemized anesthesia and time-based anesthesia. Therefore, we like to see charges created based on the anesthesia time wherever we can. So time-based anesthesia charges are based on the start and stop time of the record, same as the OR charges. And we recommend that prices reflect that resource utilization. Now, we have 6 types of anesthesia listed here. General, MAC, and moderate sedation should be time-based. Meanwhile, epidurals, locals, and blocks are one-time charges. Now, reimbursement for technical anesthesia is generally included in the overall surgical reimbursement package for Medicare. And the information is a little elusive in the Medicare claims data. So we don't have the capability to price at a Medicare reimbursement rate, a multiple of that rate, or the peer average. So we do recommend really digging into the resource utilization in these time-based increments where we can, or as one-time charges. Now, other hospitals will roll anesthesia into the case rate or surgical grouper. Other payers will either roll that anesthesia reimbursement into a case rate or a surgical grouper, but sometimes they will see a % of charge reimbursement in this area. Now let's talk about recovery, and this is the PACU side of things. General anesthesia will usually require at least 1 hour of one-on-one recovery care. And once that patient is attended to for that minimum period, and the nurse assessment determines the patient can move to a lower staffing ratio, the nurse can then attend to 2 patients. Now, pediatric patients will usually require one-on-one care for the entire recovery period. Many facilities we see will create an initial 1 hour front-loaded charge with additional 15-minute increment charges, but it is appropriate to charge by the minute. It's up to you how you want to handle your billing. From a Medicare perspective, again, reimbursement for PACU and recovery is included in that overall surgical reimbursement, so we really can't see the reimbursement of that particular charge or the peer average in the Medicare information. So this is another area we're going to look at resource utilization, keeping in mind that that reimbursement from other payers may be % of charge. And let's just throw more wood on the fire and complicating the OR service line again. So another consideration that must be made in the OR service line, which again, we're talking about the OR level, recovery, and anesthesia, relates to each facility's use of bundling charges. So in this case rate analyzer, I've got 43239, which is an endoscopy. Our demo hospital doesn't regularly bill for recovery charges separately, according to the data that we see here. They only bill it 34% of the time separately. Meanwhile, the big health facility bills recovery separately 100% of the time. Now, on the other hand, anesthesia is billed in these cases 100% of the time at both facilities. So we're seeing a separate charge code for anesthesia 100% of the time. So understanding how your competitors are charging for services like this in the OR provides additional insight on how your pricing compares in the service line. So let's talk a little bit about pharmacy charges. So drugs dispensed in a hospital setting can become a sensitive area for patients. And this is due to the patient's ability to compare prices against what they pay for their drugs at a local retail pharmacy. Now, you and I know that's not a fair comparison, but it's what our patients have. So our recommended practice is to create cost-based markups that use fixed add-ons and minimum charges to compensate for the department resources involved in storing, handling, and preparing items. So fixed add-on charges are going to be used to represent the time and resources associated with preparing or handling medications. To determine a fixed add-on, the route of administration, staff skill level, and preparation time should be considered. So the route of administration refers to how the medication is administered to the patient. IV compounded medications require more resources for preparation than pulling an oral tablet out of a machine. Fair enough, right? So a fixed add-on fee would be appropriate for an IV route medication. Now, skill level and preparation time. So that's talking a little bit more about the training and preparation time of the product itself. So if we look at chemo IV compounds, those require more training. Those technicians and those pharmacists have additional training related to chemo compounds and skill. They also take longer to prepare. So this category would probably be assigned an even higher fixed add-on fee to accommodate for that as well. And not to mention the hood requires a totally different licensing. So the preparation time and the pharmacy staff hourly rate and any additional outsourcing or handling costs are included in that fixed add-on price determination. And the last thing we look at in the pharmacy charges area is a separate markup for items considered self-administered. So the concept of self-administered drugs is challenging and can create a little bit of a compliance concern for hospitals. So self-administered drugs are defined by Medicare as drugs that are administered by the patient 50% of the time in its overall use in all settings. Let me slow that down. So defined by Medicare as drugs that are administered by the patient 50% of the time in its overall use in all settings. So even though a patient may not actually administer the topical medication during their hospital stay, since over 50% of the time it is administered by the patient when they're at home or elsewhere, it is considered self-administered. So this means that we cannot bill it to Medicare, which then causes trouble down the line when you're billing the patient for it, right? So for self-administered drugs, we recommend assigning a lower multiplier, lower minimum charge to those charge categories, just to make sure that we are lessening the impact of patient responsibility or hospital write-offs depending on your process. So the market data for areas like pharmacy and supplies should not be analyzed at the HCPCS code level. This is because the CPT HCPCS code can be used across items that have different cost bases in the markups. So for example, in the pharmacy area, you may have azithromycin that is measured out for a pediatric patient versus an adult patient. So that cost basis is different, but the HCPCS code is the same. So using that across your market is not really a fair comparison. So just like we do in the OR, we kind of go back to the 30,000 foot level and we look at the UB revenue codes for the pharmacy area to identify where we have our market opportunity. So the screenshot here focuses on the 25X and the 63X revenue codes and shows how the average compares across the revenue stream. Demo Hospital comes in at $121 on average, with the average of the market being around $333 when you include the high and low outliers here. Again, pharmacy charges generally use a markup of cost, but reviewing the market ensures that you're aware of areas that may put you on the front page of the news. Supply charges. So just like pharmacy, medical supplies are priced according to a cost-based markup. we see lower cost items are assigned higher multipliers and higher cost items are assigned lower multipliers. This is standard practice throughout the industry. Now, we do recommend using actual cost basis to price medical supplies. Many facilities, though, will employ the use of a cost threshold for low cost items. So this basically sets a rule that they will not charge for items under a certain cost. Now, the cost threshold will vary according to the facility, but I've seen it range from anywhere to $5 to $25. And by setting a minimum cost threshold for what you consider billable items, reduces the effort of nursing and materials management staff from having to chase down that charge. And so that's why we see the minimum threshold vary as much as we do. Hospitals have a different idea of the cost that's not worth the time and the resources of getting onto the patient claim. So there's no right or wrong way here. The use of fixed add-ons and minimum charges can compensate for any department resources for handling the supply, just like we see in the pharmacy area. And then finally, we recommend creating a separate and distinct markup for the implantable revenue codes. So 275, 276, 278, that's your lenses, pacemakers, and implants. We find that many facilities have payer contract terms that are sensitive to those items. So by simplifying the markup for those particular items, the carve-out language and payer contract requirements can also be simplified. Now, many facilities fall away from maintaining the relationship between cost and patient price, and this is because it's just cumbersome and hard to update, right? So the facility may use an established markup to determine the initial price of an item, but in the years to follow, they only apply an overall percent increase to all the items. So as time goes on, items that were set up, let's say 10 years ago, are going to be very different than a similar item that maybe you set up yesterday. So because of this, we are seeing hospitals moving towards standardizing their supply markup to reestablish that relationship between cost and patient price. Now, this in turn addresses any potential compliance issues associated with inconsistent charging practices. So we do recommend reviewing the charge master for what would be considered non-billable medical supplies. However, when you decide to remove those non-billable supplies from the charge master, we need to plug in increases to either room rates, ED levels, and/or operating room charges to help recover that gross revenue. Now, we'll talk a little bit about the minimum charges. I know I've been talking about fixed add-on and minimum charges. And one thing I want to demonstrate is how the use of markups that assign a lower multiplier to higher cost and higher multiplier to lower cost items looks graphically when we compare the cost to the patient charge. Now, again, this is standard practice where we have a 3x multiplier on something that costs $1,000. So as we see here, there's a huge gap on the left-hand graph around the cost of $1,000. What's happening in this example is that the facility has a multiplier of 3 on items that cost under $1,000 or between that $300 and $1,000 range, which means that $1,000 cost is being charged $3,000. However, if something costs $1,001, it's only being assigned a multiple of 2, making the patient charge $2,000. So in this situation, we're charging less for items that cost more. So again, this compressed markup is an industry standard. We just need to be careful when we're implementing it to ensure we don't have issues like we see here. So by incorporating a fixed add-on or minimum charge, we ensure that we're charging more for items that actually cost more, like we have here. So as we can see on the chart on the right, the line is now continuous due to the use of the minimum charge at each of the pricing tiers. So for our example, that minimum charge of $3,000 for items that have a cost over $1,000. Again, we're just ensuring that a facility is charging more for items that cost more for a transparency perspective. Now, as I mentioned earlier, market data for areas like pharmacy and supplies should not be looked at the HCPCS code level. You could think about C1725 or C1716, I think is the one, is a screw, right? And it's all different sizes, use that same CPT code. So when we have that sort of example, we have to kind of back up and look at the 30,000 foot level again. So this screenshot here is focused on the 27X and the 62X revenue streams to demonstrate the average across the revenue stream. Now, tackling each of these areas to create a sound pricing methodology is our first step in achieving our price transparency goals and improving the patient experience. So these strategies ensure that prices are justified according to the Medicare fee schedules, actual cost, and/or peer pricing data. Implementing these best practices can improve profitability by creating justifiable pricing methodologies that ensure transparency, competitiveness, and earned reimbursement. Identifying patient-sensitive and competitive items also helps the facility with becoming more retail-oriented. In the dawn of price transparency requirements, payer contract negotiations, reimbursement analytics, and denial management are going to become a primary focus for hospitals. So hospitals must ensure that they're doing several things. First of all, any contracts that include lesser of language, they need to be reviewed. So the facility must ensure pricing is established in a way to ensure maximum revenue. So managed care contracts sometimes include this lesser of language, and it's usually buried in a PDF somewhere that's been scanned 14 times. But it basically limits reimbursement to either a published fee schedule or the billed charge, whichever is less, right? Lesser of. So sometimes if a hospital decides to reduce prices to become more in line with the market, they may inadvertently lose revenue because of these lesser of provisions. So we have to keep sight of where those are. And with patients shopping the market for services, our recommendation is to ensure that hospital prices are in line with the average of your peer group. And after we've kind of determined what that peer average is, then we compare it to any managed care fee schedules or contracts that have that lesser of language to ensure that we're above any fee schedules to ensure that maximum reimbursement at the line item level. Now, as I discussed in the pricing strategies section, we prefer that charges be priced at a multiple of Medicare reimbursement. Now, this refers to the published OPPS payment rates for Medicare. Now, if you're a critical access hospital, this part's for you. I have many critical access hospitals coming to me saying the OPPS reimbursement doesn't matter to them because they're reimbursed based on cost. Yes, that is correct. But we find that sometimes our critical access friends have contracts that are related to the OPPS Medicare payment rates, and they don't know about them. So for example, I had a hospital who had a contract that read reimbursement will be 3 times the Medicare OPPS payment rate or the current charge, whichever is less. So this hospital is leaving money on the table because they didn't even consider that the contract would be based on OPPS payment rates. Now, Medicare payments, as I said earlier, are intended to represent the cost of providing the service. So we should make sure we're keeping an eye out to ensure that our prices are at least over that OPPS published fee schedule rate. Now, private payers set hospital prices through contract negotiations. If providers and payers are unable to reach common grounds on those contracts, then the payer will consider the provider out of network and push patients away from the hospital or the health system. So our hospitals must be agile in our ability to model contract rate proposals from payers to identify or evaluate the financial impact. Now, large payers like United, Anthem, what are they called now? Elevance, who's had an Elevance audit recently. They have armies of data economists at their disposal to ensure that they're at the winning end of negotiations. Hospitals typically don't have those types of resources. Now, sometimes we have hospitals who will contract with an outside vendor to manage, evaluate, and optimize those negotiations to achieve the required returns. Others, on the other hand, we're just holding our nose and hoping for the best, right? So it's important for us to really understand, first of all, where we stand in the market and if we're being paid correctly in the first place. So I always like to say it's important to know where you sit before you tell others where you stand. So when we go into those negotiations, having this data available at our fingertips really allows us to have something to say at the table. Again, performing those analytics around that reimbursement data, market data, identifying areas where your payers are non-compliant, those are going to be kind of the next steps as we're moving through price transparency and pricing strategies. Wow, that went fast. So this this concludes our discussion of hospital pricing optimization. I really do appreciate your time today, and as a thank you for joining us for the webinar today, we are offering we are offering a free pricing market report for up to 4 of your competitors. So if you want to take advantage of this offer, please email Rick at the email on this slide and include webinar HPS in the subject line. And this will actually expire in 2 weeks. Let's see.
Thank you.
Yeah.
Thank you so much, Randy. Great presentation. You covered a lot of, I would say, a lot of data in a short period of time, and a job well done. If you have questions, please put them in the Q&A box. Randy, I do have a couple of questions that we had sent earlier. When you think in terms of looking at charge to cost ratios, how do you measure the impact of the cost to charge ratio for critical access hospitals in your review?
Yeah, so this is always a tough area. So as I said, critical access hospitals are reimbursed from Medicare based on that cost-based system. So this means they receive payments based on their actual costs rather than a fixed schedule. So this is a little different from our OPPS friends, which are paid on DRG or APCs. Now, critical access hospitals submit those cost reports to Medicare, which details their allowable costs. And this information is used to determine their reimbursement rate. But if a critical access hospital increases its charge master prices, the immediate effect is an increase to total charges and ultimately patient copays, which we have to take into consideration. However, because they're reimbursed based on cost, it doesn't affect the actual reimbursement right away. But when the charge master prices are increased, there will be an adjustment to the cost to charge ratio. Now, theoretically, when charge master prices are increased, there will also be likely an increase in cost reflected on that next cost report as well. But how do we handle it? That's the question. So our models assume that the costs are not increasing and that the cost to charge ratio will decrease due to the increase of prices. So this really gives us a realistic picture of the impact of the CCR, hopefully a worst case scenario, right? We work with our hospitals to minimize the impact on the CCR during our strategic pricing reviews. So because critical access hospitals really operate in tight margins and serve vulnerable populations, we have to be very sensitive in those areas. So changes to the charge master price may influence our patient volumes and could lead to decreased access for care. So again, we assist our critical access hospitals in approaching that charge master pricing increase with caution and strategize to minimize those impacts as much as possible.
Another question is, when you're looking at modeling and proposing pricing for ancillary systems, many of those items are priced at the time of service. Example, pharmacy, materials management. How
Right.
do you handle modeling that?
Yeah, so ancillary systems are a little tricky because a lot of times we don't have those prices living in the charge master. But we actually leverage our models to create markups in those areas um, a little differently. So like I said in my presentation, we identify the overall market opportunity by looking at that 30,000 foot revenue code level. But we actually use the transaction data from the hospital to determine what the average price is, which then allows us to kind of determine where the cost is currently. So we take our current cost data from our hospitals and recreate the markups as they stand today, and then create a model or a new markup that goes into those industry standards that I talked about earlier with self-administered drugs or distinct markups for implants, pacemakers, and lenses. So while we realize that many times the hospital prices don't live in the CDM, our data analysts will determine the average over the course of the model timeframe using transaction data and kind of rebuild those markups.
Got it. I know a lot of the federal and state requirements for hospital price transparency, and hospitals doing their best to meet all the requirements. And I'm just curious, do you use hospital price transparency machine readable files in your analysis?
In our analysis. So the short answer is no. We prefer to get the gross charge data from the Medicare claims data rather than rely on the variety of vendors and or hospitals to post those prices in the machine readable files required under CMS. So although it might seem like an easy source of information for hospitals to use, we are finding there can be errors in the data or inconsistencies in how it's posted. So again, we like to use that CMS claims data to determine what the hospitals are charging. But my caveat is sometimes there are revenue streams that are not available in the CMS data, right? Labor and delivery, nursery charges. Those are not typically Medicare patients. So we may lean into the machine readable files just to see what's out there, but it's not something we fully rely on for an entire transparent pricing review.
Got it. You know, as you look at some of this work you're doing, hospitals, obviously have to prepare budgets and you have to do budgeting. Do you see hospitals integrating market-based pricing studies into their budget processes now that price transparency is in place?
Absolutely. So with transparency behind us, and I think I kind of talked this earlier, many hospitals are really scrambling to see how we can become more competitive in the market, not end up in the front page of the news, things like that. So they're having to really pivot to ensure that prices cover costs and are above fee schedules, but also have to keep an eye on that market. So we've focused on enhancing our models to ensure that we can handle a variety of those requests, whether it's CDM consolidation, creating competitive shoppable services within their pricing strategies, whether it's reestablishing the relationship between materials management costs and patient price, same with pharmacy, putting in these industry standards. There's a lot of different moving parts that we're seeing in the budgeting process right now with price transparency because everyone's just trying to get to a place where they can feel comfortable communicating those prices. So because we're concerned about also the payers and how they're using the transparent pricing data against our hospital partners, we want to make sure that we're able to model various scenarios and be able to have that conversation and be able to back up what we're setting our prices at.
Randy, I think that's all the questions we have pending at the moment, but I want to thank you again and turn it back over to you for any closing thoughts that you'd like to share with our participants.
Thank you so much. Yes, thank you all for taking your time to join us today. I hope I was able to give you some sort of insight and clarity on hospital pricing strategies in today's transparent marketplace. If you have any questions, if you're a shy one or you think of something later, our email addresses are here on the screen. Please do not hesitate to reach out. I'm always willing to help you guys out in these situations. And thank you for your time today.
Thank you, Randy, and thanks to all the participants. We appreciate you being on. And we're going to conclude the webinar at this time. So everyone, please have a safe day.
Thank you.
Thank you.